Welcome to Science Pills. So I want you to imagine waking up from major reconstructive surgery.
Oh man, yeah. Not a fun scenario.
No, not at all. The anesthesia is wearing off, right? And the stark reality of what just happened to your body is really starting to set in.
The pain is right there on the horizon.
Exactly. The monitor is beeping, the lights are super harsh, and a nurse walks in. And they basically give you two options to manage the impending agony. Option A is a pill that might, dangerously suppress your respiratory drive or maybe permanently rewire your brain's reward center so you crave it forever.
Which is terrifying.
Right. And then option B is like a handful of over-the-counter pills that might vaguely take the edge off while you just spend the next 2 days gritting your teeth in a cold sweat.
It's a brutal ultimatum.
It really is. And for over 2 decades, that bleak, terrifying ultimatum has just been the everyday reality of acute pain management.
It's a profound vulnerability, honestly.
Yeah.
I mean, we live in an era where we can, sequence the human genome in an afternoon.
Yeah, or use targeted immunotherapy for tumors.
Exactly. Yet when someone shatters a femur or gets a major organ transplant, the pharmacological toolkit we rely on looks, well, it looks shockingly similar to what a field medic might have used 50 years ago.
It's archaic.
It is. The choices are fundamentally blunt instruments.
And we are dealing with a massive stack of sources today for this deep dive to figure out if that era of blunt instruments is finally ending.
We have a lot of ground to cover.
We really do. We're pulling data from the FDA's official trial reports, rigorous peer-reviewed analyses in the New England Journal of Medicine, the BMJ, the journal MDPI, plus insights from Yale Medicine and the clinical guidelines from the American Society of Regional Anesthesia.
All of which are incredibly dense, highly technical documents.
Yes, super dense, but they are all circling around one specific, highly anticipated word, Suzetrigine.
Right. Marketed as Journavex.
Exactly. And the hype for Journavex is deafening. We are talking about the very first completely new class of acute pain medicine in over 25 years.
Which is huge. The scientific community rarely uses the phrase paradigm shift without, a really heavy dose of skepticism.
Right. Doctors hate that phrase.
They despise it. But Suzetrigine actually warrants the label. We're looking at a non-opioid analgesic that targets a microscopic structure called the NaV 1.8 sodium channel.
Which we're going to get way into.
Oh, absolutely. Because it essentially intercepts the pain signal at the very edge of your nervous system, well before your brain even knows you are hurt.
But we also have a mission today, right? We have to balance that excitement.
Yes, exactly. While the structural biology is a triumph, we have to look at this through a lens of extreme clinical prudence. We need to measure the sheer brilliance of its mechanism against its actual real-world efficacy.
How it actually worked in the clinical trials on real surgical patients.
Right. And crucially, a financial cost that is going to force a major reckoning in hospital economics.
So think about the stakes here, because this applies to you, the listener. Almost everyone is going to experience acute surgical or trauma pain at some point.
It's a universal human experience.
Yeah, a partner getting a knee replacement, a kid getting their wisdom teeth out, or, a sudden trip to the ER with a ruptured appendix. You are going to face this exact crossroad.
Everyone eventually meets the blunt instruments.
Right. Okay, let's unpack this. To really appreciate why billions of dollars and decades of research were poured into Suzetrigine, we have to look at the crater left behind by our previous tools.
The crater is incomprehensibly large.
Like, how bad is the crisis that actually forced this innovation?
Well, the opioid epidemic has completely reshaped public health, demographics, and economics in the U.S. If you just look at the raw numbers from the CDC for the year 2022, we saw over 100,000 drug overdose deaths in a single 12-month period.
100,000.
In 1 year.
In 1 year. And the vast majority of those involved opioids.
That's just staggering.
It's a tragedy. And the macroeconomic burden trails right behind the human tragedy. Health economic modeling projects the total cost of the opioid crisis to hit $367 billion in the year 2025 alone.
Wow, $367 billion. Yeah. And that number encompasses the immediate healthcare costs of overdoses, sure, but also the massive loss of workforce productivity, the strain on emergency response systems, and, the lifelong costs of addiction treatment programs.
But the terrifying thing about opioids is that they do work, right? Like if you have a crushed ankle, morphine will absolutely obliterate that pain.
Oh, they are incredibly effective analgesics.
But the collateral damage is systemic, so why do they cause so much devastation? Like what is the chemical trade-off happening in the brain?
The trade-off is entirely geographic. Opioids are highly effective because they mimic the body's natural endorphins and bind to specific receptors, primarily the mu-opioid receptor.
Okay, the mu receptor. Right.
The problem is where those receptors are located. They are heavily concentrated throughout your central nervous system.
So the spinal cord and the brain.
Exactly. When the drug crosses the blood-brain barrier and binds centrally, it shuts down the pain perception. But the brainstem is also where your fundamental life-sustaining reflexes live.
So it's not just hitting the pain centers.
No, not at all. By acting centrally, opioids trigger a cascade of severe, sometimes lethal side effects. They cause profound respiratory depression.
Meaning you just stop breathing.
Literally, yes. The drug binds to the respiratory control centers in the medulla and blunts the brain's sensitivity to carbon dioxide.
Wait, so the brain just doesn't realize there's too much CO2?
Right. The brain literally forgets to tell the lungs to breathe, and that is the mechanical cause of a fatal overdose.
Jeez. And even if you survive the dose, there's the psychological hijacking part of it.
Yes. The other central nervous system consequence is the activation of the mesolimbic dopamine pathway.
Which is what?
This is the brain's core reward circuit. Opioids trigger a massive, unnatural flood of dopamine, creating intense euphoria.
So you're just trying to treat a mechanical injury in your ankle.
But you are simultaneously, fundamentally altering the neurochemistry of your brain's survival and reward systems. That euphoria is the genesis of extreme addiction potential.
It's like trying to put out a small fire in your kitchen by flooding your entire house, including the electrical panel.
That's a very accurate analogy.
You might stop the fire, but you've destroyed the foundation. So for a quarter of a century, our only tools have been a feather, like weak over-the-counter ibuprofen, or this massive sledgehammer that demolishes the house.
It's been a very barren landscape for innovation.
Yeah, the literature points out the last major breakthrough was something called celecoxib back in 1998. Why hasn't there been a middle ground in almost 30 years?
If we connect this to the bigger picture, the legacy of what happened right around 1998 explains everything about this massive drought. Celecoxib was the vanguard of a class of drugs called KOX2 inhibitors.
And people were super excited about those, right?
Oh, the medical community genuinely believed they had found the Holy Grail. See, older NSAIDs, like standard ibuprofen or naproxen, they work by blocking cyclooxygenase enzymes, which reduces inflammation.
Okay.
But they block both KOX1 and KOX2. And blocking KOX1 strips away the protective lining of the stomach.
Right, which causes ulcers and bleeding if you take them too long.
Exactly, severe gastrointestinal bleeding.
Yeah.
So these new drugs specifically targeted only KOX2. They were powerful painkillers that bypassed the stomach issues entirely and had zero opioid addiction risk.
So it sounded perfect.
It did. Drugs like Vioxx and Bextra hit the market and became blockbuster prescriptions practically overnight.
But the sledgehammer swung back around, just hitting a completely different part of the house.
The fallout was catastrophic. Post-marketing surveillance revealed a hidden biological mechanism.
Wait, post-marketing surveillance, that's when they track the drug after it's approved, right?
Right. When millions of real people take a drug over years, rather than just thousands of people in a short controlled trial. And the data showed that by selectively inhibiting KOX2, these drugs disrupted the balance of prostacyclin and thromboxane in the blood.
Okay, in simple terms, what does that actually do?
In simple terms, they created a highly prothrombotic state. They were causing blood clots.
Oh, wow.
Yeah, leading to significant, fatal cardiovascular events, heart attacks and strokes.
That's horrifying. So you take a pill for a bad knee and you have a heart attack.
Exactly. Vioxx was pulled from the market in 2004, followed by others. The sheer scale of the liability and the regulatory backlash created this massive chilling effect across the entire pharmaceutical industry.
I bet nobody wanted to be the next Vioxx.
Exactly. The FDA raised the bar for safety to an unprecedented height, and companies realized that investing billions into new pain medications carried an almost insurmountable financial risk.
So the well just runs dry, the pharmaceutical companies back away, but patients are still having major surgeries.
Every single day?
Right. And doctors are desperate to avoid prescribing opioids because the addiction crisis is accelerating, but they can't use the COX-2 inhibitors anymore. So that desperation naturally leads to the off-label explosion, doesn't it? The BMJ sources highlight this whole tragic saga of the gabapentinoids.
It's a perfect example of clinical desperation driving highly questionable prescribing habits. Gabapentin and its cousin pregabalin were originally developed and approved as anti-seizure medications for epilepsy.
Seizure meds, not pain meds.
Right. But physicians noticed they seemed to quiet down hyperactive nerves, so they began prescribing them off-label for pain, particularly nerve pain.
Just kind of hoping they worked.
Pretty much. Over the last decade, as the pressure to reduce opioid prescribing really mounted, gabapentin became the default fallback. It was viewed as the safe, non-addictive, ventral nervous system-friendly alternative.
Except the actual data on how well it stops pain is incredibly murky.
Murky is a generous term, honestly.
Yeah.
The clinical studies analyzing the BMJ editorial showed that the analgesic value of gabapentin for acute pain is highly ambiguous.
Like it just doesn't work that well.
One major meta-analysis found that only 14 to 17% of patients experienced a 50% reduction in pain over a placebo.
14%. That's terrible.
It's essentially ineffective for acute post-surgical tissue pain. But the true tragedy isn't just that it doesn't work well, it's that it turned out to be incredibly dangerous.
Wait, if it's not an opioid, how is it killing people in overdoses?
Because we are now seeing data implicating gabapentin in up to 10% of fatal overdose deaths in the U.S. recently.
10%?
How? Because it acts as a severe central nervous system depressant when combined with other drugs. Patients often take gabapentin alongside a smaller dose of opioids or benzodiazepines or even just alcohol.
Oh, so it multiplies the effect.
Drastically. It amplifies the respiratory depression caused by those other substances. It fundamentally lowers the threshold for a fatal overdose.
The landscape is just overwhelmingly grim. The feather doesn't work. The sledgehammer destroys lives. The shiny new tool from 1998 caused heart attacks, and the desperate backup plan doesn't really stop pain, but still contributes to 10% of fatal overdoses.
It's a mess.
It really underscores a fundamental, terrifying truth about human biology, which is that pain is spectacularly difficult to control.
It is an evolutionary masterpiece. You have to remember, pain isn't a disease. It is an incredibly robust, multi-layered alarm system designed to keep you alive.
Right. It's a feature, not a bug.
Exactly. It alerts your brain that tissue damage is occurring so you can withdraw from the danger. Trying to dismantle that alarm system without accidentally turning off the brain's drive to breathe, or the heart's electrical rhythm, or the digestive tract's motility, it requires a level of molecular precision that we simply did not possess.
We were throwing systemic chemical bombs at a highly localized electrical problem.
That's a great way to put it.
Which is exactly why the medical community is losing its collective mind over Suzetrigine. Because to understand how this drug finally cracks the code, we have to zoom way, way down to the microscopic level.
Down to the individual cells.
Right. We need to look at the actual biological mechanics of a pain signal. Let's ground this in a very universal experience for the listener. You're walking barefoot in the dark, and you step directly onto a rogue, sharp piece of a child's plastic toy, a Lego brick.
Oh, the absolute worst.
The worst. In that exact microsecond, what is physically happening in the foot?
The architecture of that moment is fascinating. Embedded in the skin of your foot are specialized sensory nerve endings called nociceptors.
Nociceptors, okay.
Think of them as microscopic, highly sensitive tripwires. When your foot comes down on that sharp plastic edge, the extreme mechanical pressure physically deforms the cell membrane of the nociceptor.
Like stretching it out of shape.
Right. This deformation triggers the tripwire, and the nerve ending generates an electrical charge. But that local charge doesn't mean anything unless the brain knows about it.
Right. Your foot doesn't feel pain. Your brain does.
Precisely. The signal has to travel from the bottom of your foot, race all the way up your leg, enter your spinal cord, and finally reach the sensory cortex of your brain. The brain is the only place where you actually perceive the agony of stepping on the toy.
But the nerve isn't a copper wire, right? It's not a continuous flow of electricity like a power cord plugged into the wall. How does the charge actually move 3 feet up the leg in a fraction of a second?
It relies on a biological cascade called an action potential.
Action potential.
Yes. The membrane of the nerve cell is studded with tiny, complex proteins called voltage-gated sodium channels. They act like incredibly selective microscopic gates.
So little doors along the nerve.
Exactly.
Now,
When the nociceptor is triggered by the plastic toy, the first set of gates pops open. The environment outside the nerve cell is rich in positively charged sodium ions,
Okay, so the door opens.
and those positive ions rush inside the cell. This sudden influx of positive charge changes the local voltage of the nerve. That localized electrical spike is the action potential.
And that spike acts as the trigger for the next gate.
Precisely. The change in voltage causes the adjacent gate down the line to pop open, giving in more sodium, which changes the voltage further, popping open the next gate.
Oh, like a wave.
It travels down the nerve fiber exactly like a wave at a sports stadium. The gates open and close in rapid succession. The brain interprets the frequency and intensity of those waves. It's often compared to a sequence of Morse code.
The nociceptor is furiously tapping out an electrical SOS signal to the brain, warning of severe tissue damage.
Yes, the Morse code of pain.
So if you want to stop the suffering, you don't need to flood the brain with dopamine, you just need to cut the telegraph wire.
Exactly.
You have to jam those microscopic sodium channel gates shut so the sodium can't rush in, the wave dies, and the SOS signal never reaches the brain. But here's where my pharmacology knowledge hits a wall.
Okay, let's hear it.
We already have drugs that jam sodium channels. If I go to the dentist to get a root canal, they inject my gums with Novocaine. Novocaine blocks sodium channels.
It certainly does.
So if Suzetrigine is just doing the same thing, why doesn't a patient taking Suzetrigine just become completely numb and paralyzed from head to toe?
That is the multi-billion-dollar question that pharmacologists have spent decades trying to solve. You are entirely correct. Local anesthetics like Novocaine, lidocaine, or bupivacaine are potent sodium channel blockers. The critical flaw is that they are chemically non-selective. They are blunt instruments. When lidocaine encounters a sodium channel, it lodges itself into the main pore of the channel, like a cork in a wine bottle, completely blocking the flow of ions.
Okay, so it plugs the hole.
Right. But it does this to almost every single type of sodium channel it touches. And the human body doesn't just use one type of gate. We actually have 9 distinct subtypes of voltage-gated sodium channels.
9 of them.
Yes, classified from NAVI 1.1 through NAVI 1.9.
So they were distributed everywhere, doing completely different jobs.
Exactly. NAVI 1.5, for example, is predominantly found in your cardiac muscle. It dictates the electrical rhythm of your heartbeat.
That seems important not to block.
Very important. NAVI 1.4 controls your skeletal muscles, allowing you to walk, lift your arms, and, crucially, contract your diaphragm to breathe. Other subtypes handle normal, non-painful sensory input, like feeling the texture of your clothing or a light breeze on your skin.
So if you were to take a non-selective blocker like Novocaine in a pill form, so it's circulated systemically through your blood,
The result would be catastrophic. It would paralyze your voluntary muscles, cause massive cardiac arrhythmias or complete cardiac arrest, and trigger severe neurotoxicity.
which is why the dentist has to use a tiny needle to put the Novocaine right next to the specific tooth, and why you can't feel half your face for 4 hours. You have to physically isolate the blunt instrument.
Precisely. You can't put it in a pill.
So this brings us to the actual wow factor, the absolute structural brilliance of Suzetrigine. It doesn't block all 9 channels, it ignores the heart, it ignores the muscles, and it hunts down one specific subtype, NAVI 1.8.
The selectivity is the true breakthrough here. The biological role of NAVI 1.8 makes it the perfect target. It is expressed almost exclusively in the peripheral nervous system.
Meaning out in the limbs, the skin.
Yes, you will find it densely packed on those specific nociceptors, the pain-sensing nerves, but it is virtually absent from the central nervous system.
So it's not in the brain at all.
It's not in the brain, it's not in the spinal cord, and it's not in the cardiac tissue.
Oh.
Even more crucially, it is not primarily responsible for transmitting normal, light touch, or motor control.
So what does it actually do?
Its primary evolutionary job is to act as the massive engine driving the sustained transmission of moderate to severe pain. It really kicks into overdrive specifically during inflammatory states and nerve damage.
Wow. So if you engineer a molecule that only locks the NAVI 1.8 gate, you are essentially establishing a highly targeted blockade at the perimeter.
Exactly.
You intercept the severe pain signal out in the limb at the site of the injury, and you kill the Morse code before it ever crosses the blood-brain barrier. And because the drug never enters the brain, it can't bind to the mu-opioid receptors.
Right. It can't cause the brain to stop breathing, and it can't flood the reward center with dopamine.
It completely decouples potent pain relief from central nervous system toxicity.
It does. But achieving that targeted blockade required moving away from the cork-in-the-bottle approach of Novocaine. Suzetrigine utilizes what is known as an allosteric mechanism.
An allosteric mechanism. Rather than just clogging the main pipe, it's doing something more complex to the machinery of the gate itself.
Think of the sodium channel as a complex three-dimensional mechanical lock. Lidocaine works by blindly shoving a piece of gum into the central keyhole. Nothing can get through, but it fits into any keyhole it finds.
Right.
Suzetrigine, on the other hand, ignores the main pore completely. Instead, it binds to a very specific structural pocket on the outside of the channel, a region called Voltage Sensing Domain 2, or VSD2.
It's grabbing the side of the machine.
Yes, and the targeting is astonishingly precise. It recognizes and binds to a unique sequence of just 4 amino acids located on that domain. Lysine, lysine, glycine, serine.
The KKGS sequence.
Exactly. And this exact 4 amino acid arrangement is entirely unique to the NaV 1.8 channel. It simply does not exist on the sodium channels in your heart, your brain, or your motor neurons.
So the drug acts like a highly specialized key that can only slip into a lock that exists exclusively on the specific wires broadcasting severe agony.
Beautifully stated. And once it binds to that KKGS sequence, it acts like a molecular clamp. It stabilizes the domain and physically forces the gate to stay in the closed position.
So even if the nerve is trying to fire,
Even when the nociceptor is screaming, trying to open the gate to send the pain signal, the voltage sensing machinery cannot move, the sodium cannot rush in, and the action potential dies right there. The data shows that Suzetrigine has a 31,000-fold preference for binding to NaV 1.8 over any of the other human sodium channels.
31,000-fold. That's a masterclass in structural biology.
It really is.
But there is another quirk in the MDPI review that caught my eye, something that sounds like a total paradox. They describe the binding behavior as exhibiting reverse use dependence. In normal terms, if I use something more, I expect it to grip tighter. What does reverse use dependence actually mean for a nerve cell?
It is counterintuitive, but it's a brilliant safety feature. Traditional local anesthetics exhibit standard use dependence. The faster and more frequently the nerve fires, the tighter the lidocaine binds, and the stronger the block becomes, leading to total numbness.
Okay, that makes sense.
Suzetrigine does the exact opposite. Because of the specific molecular state of the gate it binds to, it actually grips tightest when the neuron is at rest, sitting in its negative voltage baseline state. If the nerve is suddenly, strongly, and repeatedly depolarized by a massive stimulus, the drug's grip can actually loosen slightly.
Wait, so if the pain gets suddenly worse, the drug lets go a little bit. Why is that a good thing?
Because it ensures the drug provides powerful, consistent tonic inhibition.
Meaning it lowers the baseline pain?
Right, it aggressively lowers the overall baseline of inflammatory pain, but it prevents a complete, irreversible pathological blockade of the nerve. It leaves the fundamental architecture of the nerve's survival function intact, just severely dampening its ability to sustain a hyperexcitable agony state.
Okay, let me visualize this. You have a patient who just had their knee replaced. They take this pill. The drug floods their system, ignores their brain, ignores their heart, finds the KKGS sequence on the specific nerves around their shattered knee, and clamps the gate shut. They can feel the bed sheets on their leg, they can consciously flex their calf muscle, but they don't feel the massive surgical trauma. It sounds like science fiction.
It does, but it's real chemistry.
But a computer model of an allosteric clamp doesn't mean anything until you give the pill to a living human being in excruciating pain. How did this actualize in the clinical trials?
The transition from theory to clinical reality was massive. To secure FDA approval, the drug went through a highly rigorous Phase 3 clinical trial program.
The ultimate test.
Right. The core data relies on 2 massive, randomized, double-blind, placebo-controlled trials involving over 2,100 adult patients. To truly test an acute painkiller, researchers chose 2 notoriously painful, very distinct surgical models, the abdominoplasty and the bunionectomy.
Let's clearly define what those surgeries entail because it explains why they are the gold standard for testing pain. An abdominoplasty is a tummy tuck. You are making a massive hip-to-hip incision, detaching the skin and fat from the abdominal wall, frequently suturing the underlying abdominal muscles back together, pulling the tissue tight, and excising the excess. It is a massive area of trauma.
Exactly. It creates a vast, inflammatory soup of damaged tissue. It is the premier clinical model for evaluating severe soft tissue pain.
And a bunionectomy is entirely different.
Completely different. A surgeon cuts into the foot, strips the tissue back, uses a saw to cut the metatarsal bone, realigns the joint, and often drives metal screws or pins into the bone to hold it in place.
So, drilling into bone.
Yes, it is the classic, highly localized model for hard tissue or bone pain. By succeeding in both models, a drug proves it can handle the two primary domains of post-surgical agony.
But how do you actually measure the success? Like, if I take a blood pressure medication, a doctor wraps a cuff around my arm and sees the numbers go down. Pain isn't entirely subjective. My experience of a level 8 pain might be your level 4. How did the FDA objectively evaluate if Suzetrigine was working better than a sugar pill?
It is the eternal frustrating challenge of pain research. You simply cannot draw blood to measure suffering. The trials rely on a rigorously validated statistical metric called the SPID-48.
SPID-48, okay.
That stands for the time-weighted sum of the pain intensity difference over 48 hours.
That sounds like a terrifying calculus exam. Let's break down what SPID-48 actually measures in the hospital room.
It's essentially calculated the total volume of relief over time. A patient wakes up from the tummy tuck. Before they get any medication, they are asked to rate their pain on a standard 11-point numeric pain rating scale.
0 is no pain, 10 is the worst imaginable.
Exactly. That establishes their baseline agony. Over the next 48 hours, they are repeatedly asked to rate their pain again. The researchers plot those numbers on a graph. The SPID-48 calculates the total area under the curve of their pain reduction.
So it measures both how much the pain dropped and how long it stayed low.
Right. It measures the depth of the pain drop multiplied by how many hours that relief was sustained. A higher SPID-48 score means a massive sustained reduction in overall suffering.
And when they ran the math on the abdominoplasty patients, Suzetrigine clearly separated from the placebo. The high-dose Suzetrigine group hit a SPID-48 score of 118.4, while the patients suffering through the placebo only scored a 70.1.
That is a highly statistically significant victory.
It is. But honestly, the metric that blew my mind wasn't the total volume of relief. It was the onset time.
Onset is everything to a patient.
Exactly. When you are lying in a recovery bay in level 9 pain, every single minute feels like a suffocating hour. You are just watching the clock, waiting for the drug to kick in.
The pharmacokinetics of onset are absolutely critical for acute pain.
In the tummy tuck trial, the patients who swallowed the Suzetrigine pill experienced meaningful pain relief, which the trial defined as a solid 2-point drop on that 0 to 10 scale in just 119 minutes.
Just under 2 hours.
Right. Now, 2 hours might sound like a long time, but compare it to the placebo group. The patients receiving no active drug didn't experience a 2-point drop in pain for a staggering 480 minutes.
That's a profound difference.
That is 8 solid hours of unmitigated white-knuckle agony before their bodies naturally started to adapt to the trauma. Cutting that wait down to under 2 hours with an oral pill is huge.
For an oral medication, 119 minutes is a highly successful pharmacokinetic profile. Think about the journey of the pill. It has to be swallowed, broken down in the highly acidic environment of the stomach, absorbed through the intestinal wall, pass through the liver, enter the systemic circulation, and finally distribute out to the peripheral tissues to actually find those specific NAVI 1.8 channels.
That's a long trip.
It is. Achieving a reliable bridge to comfort in that time frame for severe soft tissue surgical pain is a major clinical victory.
So what does this all mean? I have to push back on the scope of these trials. A tummy tuck and a bone saw to the foot sound excruciating, and I wouldn't want to endure either without serious pharmacological help.
Nobody would.
But are they truly representative of the absolute worst-case scenarios in human medicine? If it works for a bunion, does that guarantee it works for a patient who just had their spine fused with titanium rods? Or someone brought into the ER after a massive multi-trauma car crash? Are we declaring victory over pain based on a relatively narrow slice of surgical procedures?
That is the exact limitation currently being heavily debated by clinical critics. The FDA standardizes abdominoplasty and bunionectomy because they are highly reproducible.
Meaning every surgery is basically the same.
Exactly. The surgeon makes the exact same cuts every time, which drastically reduces statistical noise in the data. But it undeniably limits the generalizability of the data. A multi-level spinal fusion or a massive crush injury involves pain that is exponentially more intense and complex.
Right, because things are torn and shattered randomly.
Yes, you are dealing with severe neuropathic pain, actual severing of major nerve trunks, alongside the standard inflammatory pain.
And the trial only tracked the pain for 2 days.
Precisely. The primary endpoints were strictly bounded to a 48-hour window. Now, they did conduct an open-label safety extension study, allowing patients to take Suzetrigine for up to 14 days for a wider variety of injuries, like severe sprains or minor fractures.
And how did that go?
The observational data there was positive, with over 83% of patients rating their relief as good to excellent. But the hard boundary remains. Suzetrigine is currently indicated exclusively for short-term acute pain, capped at a 14-day duration.
So it's not a lifelong solution.
No. It has not been proven effective as a standalone monotherapy solution for catastrophic, complex trauma, nor is it approved for chronic, years-long pain conditions.
So we have established that it works reliably for moderate to severe acute pain for a couple of weeks. But earlier, we talked about the sledgehammer effect of opioids, the central nervous system depression, the terrifying respiratory risks, the dopamine flood. If suzetrigine is going to actually replace opioids on the surgical ward, its safety profile has to be unimpeachable. How did it perform when scrutinized for central nervous system toxicity?
The safety profile regarding addiction and respiratory depression is the absolute defining triumph of this molecule, because the structure of the drug prevents it from crossing the blood-brain barrier in any pharmacologically significant quantity, and because its mechanism of action is completely distinct from the mu-opioid receptors, it entirely bypasses the mesolimbic dopamine reward pathway.
The brain's reward center remains completely dark. The brain doesn't even register that a drug has been taken.
Exactly. There is zero physiological evidence of addictive potential. During the preclinical phases, researchers ran exhaustive animal models, specifically focusing on primates, to test for behavioral signs of addiction.
How do you test a monkey for addiction?
Well, when you give opioids to primates, you universally see highly specific liking behaviors. They show sedation, they exhibit intense drug-seeking behavior, and if given a lever, they will rapidly self-administer the opioid.
Okay, and with
When administered suzetrigine, the primates showed absolutely none of these behaviors. They didn't care about it. Furthermore, the molecular structure was aggressively screened against a panel of 44 distinct molecular targets known to be linked to drug abuse potential.
Like what?
Various dopamine transporters, serotonin receptors, cannabinoid receptors. Suzetrigine did not meaningfully interact with a single one.
Which sets up what is genuinely my favorite part of reading through these medical journals. Because we have to look at the side effect comparison, and the juxtaposition is almost absurd.
It really is night and day.
Think about the reality of the opioid crisis we discussed. If you look at a standard prescription bottle of oxycodone today, you are confronted with a black box warning, the highest level of FDA alert. It warns of life-threatening respiratory depression, coma, profound sedation, and a highly addictive profile that has literally hollowed out communities across the country. That is the terrifying baseline of pain management.
The systemic risks of opioids are profound and well documented.
And then you flip to the safety data from the suzetrigine clinical trials, the most commonly reported adverse event from patients taking this revolutionary, highly advanced new painkiller. The #1 complaint in the dataset. Are you ready?
Go for it.
Occurring in roughly 2.1% of patients, the primary side effect was pruritus, which, stripped of its Latin medical terminology, means itchy skin.
That's it. Itchy skin.
I mean, it's honestly ridiculous when you think about it. Just imagine a pharmacist handing over a bottle of this drug, leaning over the counter, and saying with utmost seriousness, caution. This powerful medication may cause your left arm to feel slightly itchy for an hour.
It is a rather stark contrast, isn't it? When the primary concern shifts from will the patient stop breathing in their sleep to will the patient ask for some hydrocortisone cream, you have fundamentally altered the risk-benefit calculation for the prescribing physician.
I think most people would happily trade an itchy arm and a mild headache, which is also reported at low levels, for the guarantee that they won't wake up with a chemical dependency. Even the standard non-lethal miseries of opioids, like the severe nausea that keeps people vomiting for days after surgery, were essentially eliminated.
The nausea reduction is huge for patient comfort.
Right. The trial data showed the rates of nausea and dizziness on suzetrigine were actually numerically lower than patients who were taking the weak hydrocodone comparator. But to maintain our clinical prudence, there was one biochemical anomaly in the blood work that caught the FDA's eye. Something involving a specific enzyme.
Yes. While the central nervous system was completely spared, no systemic pharmacological intervention is entirely without a footprint. The clinical data did reveal a biochemical quirk regarding an enzyme called creatine phosphokinase, or CPK.
CPK, what does that do?
CPK is a highly crucial enzyme, primarily located inside your muscle cells, your heart, and your brain. It helps cells generate the energy required for contraction. Routine blood tests on some patients taking suzetrigine showed elevated levels of CPK in their bloodstream.
Why is an elevated enzyme in the blood a red flag for a doctor? What does that actually mean for the patient's body?
In a clinical setting, if a doctor sees CPK spilling into the bloodstream, It is often a biomarker for muscle tissue breakdown. If a muscle cell is damaged, it cracks open and leaks CPK into the blood. In severe cases, this is called rhabdomyolysis, which can aggressively damage the kidneys.
Oh, wow. So the drug was destroying their muscles.
No, and it is vital to contextualize this. In the Suzetrigine trials, the CPK elevations were overwhelmingly asymptomatic and transient. The patients didn't feel any muscle weakness or pain, and the enzyme levels naturally returned to baseline without any medical intervention.
Okay, so it was just a weird blip on the blood test.
Right, but it is a measurable physiological marker.
Hmm.
It requires physicians to exercise caution and monitor blood work, particularly if they are prescribing suzetrigine to a patient with a pre-existing muscle disease or someone taking heavy statins that already stress the muscle tissue.
So it's not a silver bullet without any systemic effects, but it's a massive safety upgrade, which makes the next phase of our deep dive so fascinating. We've established the structural brilliance, the incredibly targeted mechanism, and a safety profile that renders addiction obsolete. It sounds like an absolute miracle.
It has a lot going for it.
Here's where it gets really interesting. Because when the critics drill into the actual efficacy data, the raw stopping power of the drug, the excitement hits a massive speed bump. The FDA granted this drug breakthrough therapy and fast-track status. But when you look at the raw numbers, the actual pain relief it provides is surprisingly modest.
Modest is the correct term. It is the crux of a major ongoing debate within the pain medicine community right now.
Why did they fast-track it if it's modest?
The FDA aggressively fast-tracked suzetrigine because the societal public health need for any non-opioid alternative is so utterly desperate. But when you strip away the contextual excitement of the safety profile and evaluate the drug purely on its analgesic power, it does not blow the doors off the hinges.
To understand why, we have to look at how the trials were designed. They didn't just give one group suzetrigine and the other group a sugar pill, right?
No, they ran an active comparator arm.
Right. They gave a third group of surgical patients a standard opioid to see how the new drug stacked up against the old sledgehammer.
Exactly. And the context of that comparator is critical. The active opioid control group was given a combination pill of 5 milligrams of hydrocodone mixed with 325 milligrams of acetaminophen, dosed every 6 hours.
Which is basically Vicodin.
Right. And in the realm of acute post-surgical pain management, that is a relatively weak, low-dose oral regimen. It is the kind of prescription you might get for a moderate dental procedure, not necessarily the heavy IV narcotics used immediately post-op.
So they put the revolutionary, highly targeted NaV 1.8 inhibitor into the ring against a low-dose generic Vicodin. How did suzetrigine actually perform against this relatively lightweight opponent?
The results were highly sobering for anyone expecting an immediate end to opioids. In the abdominoplasty trial, the tummy tucks, suzetrigine was merely comparable to the hydrocodone-acetaminophen combination.
Why did it beat it?
It didn't provide superior relief. It essentially fought the weak opioid to a statistical draw. But the data from the bunionectomy trial, the hard bone pain, was even more challenging. In that trial, suzetrigine actually performed slightly worse than the low-dose opioid.
The numbers on that are just stark. The SPID-48 score, that massive calculus metric measuring total pain relief for the patients on suzetrigine, was 99.9. The patients taking the generic hydrocodone scored a 120.1.
That's a significant difference in favor of the older drug.
The weak, old-school opioid objectively provided a greater cumulative reduction in bone pain over 2 days than the cutting-edge non-opioid.
That data point forces an incredibly difficult conversation. We have engineered an incredibly safe mechanism, but the raw efficacy is inferior to a low-tier opioid.
It feels a bit like the automotive industry. Imagine a company announces they have invented a revolutionary, ultra-safe electric vehicle. The battery technology is flawless, it has zero emissions, and it is physically impossible for the car to ever explode in a crash. It is the safest vehicle ever designed.
Sounds perfect so far.
Right, but when they finally let you drive it, you realize the top speed is 14 miles an hour. Yes, it's incredibly safe and it's great for the environment, but if you need to merge onto a major highway, a golf cart just isn't going to get the job done. Are we setting a precedent where we accept mediocre pain relief, where we let patients suffer more simply because we are terrified of prescribing opioids? Is minimal viability the new standard?
That exact philosophical tension is the primary focus of the BMJ editorial we reviewed. The authors argue that the FDA's intense, arguably singular focus on non-opioid safety might be inadvertently diluting the scientific rigor regarding actual efficacy.
We're lowering the bar for pain relief.
Exactly. If regulatory bodies establish a precedent where a drug's pristine safety profile can eclipse its modest ability to actually perform its primary function, stopping severe pain, we risk unfavorably incentivizing the pharmaceutical industry.
So companies will just make safe, weak drugs.
The fear is that companies will pour billions into developing minimally viable safe drugs, knowing they will get fast-tracked, rather than taking the massive financial risks required to push the envelope for therapies that are both perfectly safe and massively transformatively powerful.
And that minimal viability argument goes from a philosophical debate to a screaming match when you look at the price tag. The economics of this drug are going to cause massive friction.
The financial disparity is vast. The wholesale acquisition cost, the list price for Suzetrigine, has been set at $15.50 per pill.
$15.50 per pill.
Yes, and the standard dosing protocol requires an initial loading dose followed by 2 pills a day. That brings the cost of a typical acute 1-week supply to approximately $420.
$420 for a week of moderate pain relief. If a hospital pharmacy buys a massive bulk bottle of generic hydrocodone, what does that cost? A few cents per pill.
Literally pennies. The generic opioid is practically free compared to the branded novel agent.
That is a massive gap.
But the cost friction is magnified exponentially by the clinical reality of how Suzetrigine actually performs in the wild. Because it provides modest relief, it rarely stands alone. In the 14-day open-label safety study, an astonishing 73% of the patients taking Suzetrigine still required secondary rescue medications.
Wait, 73%? What kind of rescue meds?
Specifically, heavy doses of NSAIDs like ibuprofen or naproxen. They needed them just to adequately handle their breakthrough pain.
So an insurance company is being asked to pay $400 for a high-tech pill, and the patient still has to raid their medicine cabinet for Advil just to make it through the night.
That is the reality of the data.
I can already hear the insurance executives typing up the denial letters. But it's not just the financial cost. The pharmacology of how the liver breaks down this drug creates a massive hurdle for doctors trying to prescribe it. Let's talk about the CYP3A4 enzyme, because this is a fascinating bottleneck.
It is a critical note of prudence for any prescriber. Once Suzetrigine has done its job clamping the NaV 1.8 channels, the body has to clear it out. That metabolic heavy lifting is done almost entirely by the liver.
Right, the liver filters everything.
Specifically, utilizing an enzyme pathway known as cytochrome P450-3A4, or simply CYP3A4.
If you read pharmacology reports, CYP3A4 is everywhere. It feels like it breaks down half the drugs on the market.
These are the primary metabolic workhorse of the human body, and that is exactly the problem. Because CYP3A4 is responsible for metabolizing so many different substances, it is highly susceptible to competitive inhibition.
Meaning other drugs can get in its way.
Yes. If a patient takes another drug that aggressively binds to and inhibits the CYP3A4 enzyme, the liver suddenly loses its ability to break down the Suzetrigine. The Suzetrigine essentially gets trapped in the bloodstream, and its concentration spikes dramatically and unpredictably.
If the concentration spikes, you suddenly magnify the risks of those side effects we talked about. The CPK enzyme elevation in the muscles could shift from a harmless anomaly to a genuine risk of tissue damage.
Correct. The prescribing guidelines are very strict. Patients cannot take Suzetrigine if they are concurrently taking strong CYP3A4 inhibitors. This creates a complex puzzle for a physician managing a postoperative patient who might have multiple comorbidities.
So what are some common drugs that block this enzyme?
You cannot prescribe Suzetrigine if the patient is on certain common macrolide antibiotics like erythromycin. You cannot use it if they are taking verapamil, a very common cardiovascular medication used for high blood pressure and angina. It is contraindicated with several major antifungal medications like ketoconazole.
Wait, if it relies entirely on the CYP3A4 pathway, isn't that the exact same metabolic route that gets blocked by certain foods? The one that causes pharmacies to put those giant warning stickers on pill bottles. Does a patient taking this for a tummy tuck suddenly have to change their diet?
They absolutely do. It is explicitly noted in the clinical warnings that patients must strictly avoid food or beverages containing grapefruit while on Suzetrigine.
Grapefruit?
Yes, grapefruit contains compounds called furanocoumarins, which violently inhibit the CYP3A4 enzymes located in the wall of the small intestine. Drinking a glass of grapefruit juice while taking Suzetrigine can massively spike the drug's bioavailability, flooding the system.
That's wild, just from a glass of juice.
And it gets more complicated.
Yeah.
Because of complex metabolic interactions, Suzetrigine may temporarily reduce the effectiveness of certain systemic hormonal contraceptives.
Birth control.
Right. Women of childbearing potential are required to use alternate non-hormonal birth control methods during the treatment window and for a specified period after discontinuation.
When you lay all of that out, the picture gets incredibly complicated. We have a drug that is a verified scientific marvel. Its mechanism is flawlessly targeted, it is completely devoid of addiction potential, and it won't suppress your breathing.
Mm.
But it is wildly expensive, its raw pain-stopping power is mathematically inferior to a weak generic opioid. 70% of patients still need ibuprofen to survive the day, and you have to navigate a minefield of drug interactions involving antibiotics, blood pressure meds, and breakfast juice.
It's a lot to manage.
If I'm a hospital administrator or chief surgical officer, how on earth do I integrate a drug with that kind of profile into a modern hospital setting?
You integrate it by recognizing that the entire philosophy of postoperative care has fundamentally changed over the last 2 decades. To understand the true utility of Suzetrigine, you have to look at the rise of ERAS protocols.
ERS, enhanced recovery after surgery. This is a massive shift from how surgery worked a few decades ago, right?
Yeah. A total paradigm shift. Historically, the surgical model was brutal. Perform the massive tissue dissection, hook the patient up to an intravenous drip of heavy opioids like morphine or Dilaudid, enforce absolute bed rest for a week, and hope the body slowly healed.
Just knock them out and let them lie there.
Today, that approach is considered antiquated and dangerous. The core philosophy of ERS, pioneered in the 1990s but heavily optimized today, is to aggressively manage the patient's physiological stress before, during, and immediately after the operation to massively accelerate mobility and recovery.
Get them up and walking on day one.
Exactly. And the foundational pillar of ERS is multimodal analgesia.
You stop relying on the sledgehammer. You don't just use one massive drug to knock out the brain. You use a synchronized team of smaller tools to attack the pain from multiple different biological angles simultaneously.
Exactly. You administer intravenous acetaminophen to raise the overall central pain threshold. You deploy powerful NSAIDs to aggressively reduce local tissue inflammation at the incision site. The anesthesiologist might perform a targeted regional nerve block, injecting local anesthetics around specific nerve bundles.
And now, in this modern paradigm, you introduce Suzetrigine.
Yes, its specific job is to chemically clamp the NaV 1.8 channels and neutralize the hyperexcitable inflammatory pain signals radiating from the damaged nerves. Suzetrigine is not designed, nor is it intended, to be a standalone miracle pill that magically erases all human suffering.
It's just one piece of the puzzle.
It is a highly specialized team player. It is a foundational pillar in a multimodal strategy whose ultimate overarching objective is to completely eliminate opioids from the surgical ward.
Because even if Suzetrigine is mathematically only as effective as a weak Vicodin, its true clinical value isn't measured solely by the pain it stops. Its massive value lies in the devastating opioid side effects it prevents.
What's fascinating here is the health economic modeling behind that exact premise, and it is how hospitals will absolutely justify the cost. Yes, the Suzetrigine pill costs $15.50, but you cannot compare that to the pennies it costs to manufacture a generic opioid. You have to compare it to the total systemic cost of administering that opioid.
The hidden costs.
Right. Opioids cause severe gastrointestinal paralysis, a condition known as postoperative ileus. The bowel simply stops moving. A patient who develops ileus after a routine bowel resection cannot digest food and cannot be safely discharged.
So they're stuck in the hospital.
They might spend an extra 3 or 4 days stranded in a hospital bed waiting for their gut to wake up.
And a single night in a monitored hospital bed costs thousands of dollars. The $400 pill suddenly looks like a bargain if it gets the patient out the door 3 days earlier.
Precisely. And the macroeconomic scale goes far beyond a prolonged hospital stay. What is the true cost of a single patient developing opioid use disorder?
You can't even put a number on that.
The data is tragically clear. Opioid-naive patients exposed to narcotic prescriptions for routine, acute post-surgical pain have a highly measurable, significant risk of developing long-term chemical dependence. The societal cost, the medical intervention, the loss of employment, the destruction of family units, the cost of a new case of OUD is virtually incalculable.
It destroys everything.
Comprehensive health economic analyses argue that by preventing opioid-induced prolonged hospitalizations and by acting as a rigid firewall against new cases of addiction, Suzetrigine is actually a macroeconomic cost saver. Over a 15-year horizon, effectively replacing a significant percentage of acute opioid prescriptions with targeted non-opioid alternatives could literally save the U.S. healthcare system billions of dollars.
It is the ultimate medical manifestation of the old saying, An ounce of prevention is worth a pound of cure. You gladly pay $400 up front to avoid a potential $1 million tragedy down the line. But that still begs a highly practical question. In the real world, insurance companies use rigid algorithms. If this becomes the standard of care in ERS protocols, will an insurance adjuster actually approve a $400 non-opioid when their computer screen clearly shows they can just authorize a $5 bottle of opioids and shift the long-term addiction risk onto the patient?
It is the defining friction point of modern American medicine. The constant war between clinical ideal and payer reality. Initially, the rollout will absolutely face steep prior authorization hurdles.
They're going to deny it a lot at first.
Insurance companies are structurally designed to be risk-averse and fiercely cost-conscious in the short term. However, the external societal, political, and regulatory pressures surrounding the opioid epidemic are immense. We are already seeing aggressive legislative movements at both the state and federal levels, pushing mandates for insurance coverage of non-opioid pain alternatives.
Forcing their hand.
Furthermore, as massive hospital conglomerates adopt these ERS protocols and begin publishing hard, peer-reviewed data proving that utilizing Suzetrigine measurably reduces length of stay and postoperative readmission rates, the payer paradigms will be forced to adapt. The economic argument of avoiding prolonged hospitalization is highly persuasive to an actuary.
And the pharmaceutical company behind Suzetrigine, Vertex, isn't just resting on the laurels of acute pain, are they? This feels like a beachhead invasion. Acute surgical pain is a massive market, but chronic pain is an entirely different, vastly more complex beast. What does the pipeline actually look like?
The pipeline is highly aggressive. While Suzetrigine currently holds an indication strictly for acute pain up to 14 days, Vertex is already deeply invested in Phase 3 clinical trials, testing the exact same molecule against diabetic peripheral neuropathy, or DPN.
DPN is the chronic nerve damage caused by long-term high blood sugar. It strips the myelin sheath off the nerves, resulting in a constant, agonizing burning, tingling, and numbness, usually in the hands and feet.
It affects millions of people globally.
Yeah, it's incredibly common.
And the current pharmacological treatments for DPN are notorious for their lack of efficacy and their devastating side effects: heavy sedation, severe cognitive fog, significant weight gain. If Suzetrigine, a peripheral NaV1.8 inhibitor, can provide meaningful relief for chronic neuropathic pain without sedating the patient or clouding their mind, the clinical impact and the market size would be astronomical.
What about other types of nerve pain?
They're also exploring its efficacy in lumbosacral radiculopathy.
Which is what?
That's the severe chronic sciatic nerve pain radiating from the lower back down the leg. Early Phase 2 data there showed it didn't statistically separate from placebo, which really highlights the incredible difficulty of treating compressive nerve pain. But the research is relentlessly ongoing.
And they aren't just betting the entire farm on this single Suzetrigine molecule, are they?
Not at all. Suzetrigine is merely the vanguard. They are already developing next-generation molecules. They have a compound currently known as VX-993 in clinical development.
Is that also targeting NaV1.8?
It is another highly selective NaV1.8 inhibitor, but it is engineered to be structurally more potent and vastly more flexible. They're exploring formulations that include both a daily oral pill for outpatients and a rapid-onset intravenous injection for immediate use in the emergency room or the operating theater. Suzetrigine proves that the NaV1.8 lock can be picked safely. It has kicked open the heavy iron door to a completely new frontier of pharmacology.
We have covered an immense amount of scientific and economic ground today. Let's pull all of these threads together for you, the listener. We started by looking back at a bleak 25-year pharmacological drought, a landscape where doctors and patients were trapped between the terrifying respiratory and addiction risks of the opioid sledgehammer and the sheer inadequacy of over-the-counter pills or off-label gabapentin.
It was a broken system.
And then we zoomed in on the biological breakthrough, Suzetrigine, a drug that acts with a staggering 31,000-fold precision to bind to the unique KKGS sequence on the NaV1.8 sodium channel. It acts as a molecular clamp, intercepting the Morse code of severe pain out in the peripheral nervous system before it ever reaches the brain.
We critically examined the clinical crucible, too. The rigorous trials proving that it can significantly reduce the severe inflammatory and bone pain of tummy tucks and bunionectomies. And it does so without ever triggering the mesolimbic dopamine reward pathway, rendering it entirely free of central nervous system toxicity and addictive potential.
But we also heavily applied the lens of prudence. We acknowledged the friction points. The drug is incredibly expensive compared to generics. Its raw analgesic power is mathematically modest compared to strong opioids. It requires a multimodal approach, often involving heavy NSAID rescue doses. And it comes with strict metabolic warnings regarding liver enzyme interactions, antibiotics, and grapefruit.
It's not a magic wand.
No, but it is undeniably a monumental step forward, giving us a genuinely safe, highly targeted tool against acute pain. But it is a specialized tool that requires smart, strategic deployment within modern ERAS surgical recovery protocols to justify its cost and maximize its benefit.
Which brings us to a final, incredibly provocative thought. We have spent this entire deep dive analyzing a chemical pill, a molecule that temporarily wedges itself into a microscopic sodium channel gate. But if we have now successfully mapped the exact molecular battery of pain in the peripheral nerves, if the scientific community knows beyond a shadow of a doubt that the NaV 1.8 channel is the primary engine driving our physical suffering, what is the next logical ultimate frontier?
This connects directly back to the Yale medicine research in our source stack, doesn't it? The work looking decades into the future.
It does. Dr. Stephen Waxman at Yale, whose early groundbreaking research actually laid the theoretical foundation for targeting NaV 1.8 over 2 decades ago, is already looking far past small molecule pills. His team is actively researching how highly targeted gene therapy might be utilized to control pain in the future.
Gene therapy, using viral vectors to alter DNA just to treat a painful injury.
Imagine a future where instead of swallowing an expensive pill every 12 hours and worrying about liver enzymes or grapefruit juice, a physician administers a highly localized, temporary genetic edit.
So they literally change your genes.
A localized therapy that utilizes your own cellular machinery to simply stop expressing the NaV 1.8 channel in the damaged nerve tissue for a few weeks while the wound heals. Instead of trying to constantly flood your system with chemicals to block a gate, you temporarily rewrite the local genetic code so the gate isn't even built.
Wow.
You essentially turn off the specific biological hardware that broadcasts severe pain, completely circumventing daily pharmacology, systemic drug interactions, and off-target side effects. It would fundamentally and permanently rewrite the human experience of physical suffering.
That is absolutely mind-bending. The idea that we could essentially issue a targeted temporary software patch to our own nervous system to simply delete the sensation of severe pain while the body physically repairs itself, it makes you realize that Suzetrigine, as revolutionary as it is today, isn't the finish line. It really is just the starting pistol for a massive revolution in how we understand and master the limits of human biology.
The next 20 years are going to be fascinating.
Thank you for joining us on this deep dive into the end of the 25-year drought in pain medicine. It is a profoundly complex topic, balancing the incredible sci-fi promise of new molecular science with the grounded economic reality of clinical prudence. Keep reading, keep questioning the science shaping your world, and we'll see you next time.